so that we don't have to steal a lot of time to our panelists, because we are all here to listen to them. So thank you very much for being here today. My name is Andrea Canini, and I am the coordinator of Young EFPC and an executive board member of the European Forum for Primary Care. I am a family doctor, and I'm going to moderate the table today. We are about to start this very interesting webinar on navigating challenges and empowering the next generation of family doctor, a Kenyan, Kazakhstani, and British perspective. I think that this webinar is going to be kind of new also within the EFPC, as we are about to introduce the experience of 3 GPs coming from 3 different countries and 3 different continents. So this is going to be for sure a very enriching exchange of experiences and of opinions. And we will probably organize by 2024 another webinar, a similar one, with nurses. And the idea behind the organization of this webinar, of course, is to bring together similar professionals and also different types of professional, and exchanging experiences from different countries. Of course, we know that we are living, I would say globally, in a time of constraint and resource reduction for the health system, and in particular for primary health care. And this is something of concern to all of us. In these conditions, becoming a new GP, a young GP, is often difficult, and is a pathway that is obstacled with many different obstacles. So we will talk today about these obstacles, how it is to start our own career in a time of collapsing health systems, and in a time in which, unfortunately, primary health care is not still valued as it should be, although we know that it's paramount for universal health coverage and to have a just and equitable health system. I just want to remember to you that, of course, this webinar is going to be recorded, so please be aware of this. And I will now introduce you our first panelist, which I would say is a friend of us, because she participated also in our last Congress in Barcelona. Mercy Wanjala, a GP from Kenya and the coordinator of Afro-PHC Forum. So thank you very much, Mercy, for being here today with us, and welcome back again. And you have the floor.
Thank you very much, Andrea. I think today I'm just going to talk about a lot about what the theme through my own life experience from when I started as a young doctor. Just giving you a bit of the context of what it's like in Kenya. So in Kenya, you start medical school and we used to do either 5 years if you're doing the crash program that we had at that time, or you do 6 years, and then you go for an extra year of internship. After the extra year of internship, you qualify now to be a medical doctor, and you get designated as a medical officer. So basically, a medical officer is someone who can do can tackle both medical cases and surgical cases, because we do a Bachelor of Medicine and a Bachelor of Surgery. So when it comes to cesarean sections, many general surgical cases like appendicitis, a lot of abdominal surgeries we can do by ourselves by that time. So after that, the trend has always been you work for government. And now we have 48 governments, 1 national government and 47 county governments. So once you leave the internship center, most of the time you're absorbed by the hospital where you are training, or if you don't want to stay in the county, in the hospital where you're training, you can go elsewhere. But after, I think around 2015 is when things began to change, and counties started saying they don't need too many doctors, they can't afford them. And the language at that time was, there's a ballooning wage bill, so we can't absorb all of you. So some of you have to leave. So like for my group, we were 16, they were only absorbing 8. I actually almost didn't get absorbed. Someone had to intervene in my case for me to get absorbed in the county where I'm currently working. So since then, things have actually gotten worse, because you find now that counties are not absorbing any medical officers. So you've gone to school, you've finished, you've qualified, but you have nowhere to work. And even if you get somewhere to work, whether in the counties or you go to a private hospital, the terms for working are very poor, because you work very hard, so many hours, but the pay is quite reduced. Like at some point, I remember hearing from some medical officers who were saying that they're paid per month, what is roughly $800, between $600 and $800 a month. And I was actually quite shocked, because now, since you flooded the market, you know, there's the appearance of you flooding the market, because Kenya right now, I think we have about 20,000 doctors to a population of about 50 million. So that's not enough. But because of the way the systems have changed, the political landscape that we have right now, there's an appearance of the fact that the market is flooded with doctors, which is not the case. Because like I have had to work as a single doctor in a whole sub-county several times, but they're not hiring more. And the other thing I think that we have had to experience is not being promoted. You work, like for me, I have been a doctor for 9 years, family physician for about 2 now, because here in Kenya, the medical officer also serves sometimes as a general practitioner, or the equivalent of what a general practitioner would be in other countries. And you don't get promoted, so you're not moving up career-wise, you're not progressing. Or you find that you're given extra responsibility, like being a medical superintendent in a hospital with no extra pay, with no extra benefits. So you're just being given the same pay, you're doing clinical work, you're doing administrative work, which you've not been trained to do, but you're forced to do. So that has been the experience and also the situation. So I think for me, I had my aha moment in 2015 when I was posted to a rural health center where I am currently, and I was posted as a medical officer. So I worked in the comprehensive care center where we have the HIV/AIDS patients for a while. And then suddenly after that, I was told, take leadership in the facility. So I became the medical officer in charge of administrative work. But as I sat there, as I saw patients and at the same time tried to manage the facility, I realized, first of all, I had no power. I was at the bottom of the food chain. That was my aha moment. Yes, you've been given some responsibility. Yes, you have all these skills that you've gained over 6 years or more, but someone else somewhere has sat and decided which drugs are going to come to your facility, when they're going to come there, how many of them are going to come there because of the budget. And that's when I realized, despite all these years of schooling, despite all your skills and knowledge, you're at the bottom of the food chain. You have no control over the facility. You have no control over patient care. You have no control over quality of care. I think that is when I made up my mind that I'm no longer going to be at the bottom of the food chain. I have to do something about it. Then thinking about all we have to sacrifice to go through medical school, I think also that struck a nerve. And I was like, no. 6 years of this, plus all the sacrifice you made before that to ensure that you got into medical school, like sleeping at 2 a.m. and waking up at 5 a.m. Like, it's crazy. Like, you were a child back then, but you're still trying to get to medical school. So I was like, all that time and sacrifice has to account for something. So I looked at where I was at that moment and asked myself, what do I need in terms of skills and knowledge to get on the table where I can also make decisions? Because I didn't like the fact that someone was making the decisions for me and controlling everything, my career progression, how I see my patients, how I feel about my career. So that's when I started doing a few courses in leadership, building onto my skill in things like facilitating and teaching. Like I did a lot of training in courses on emergency obstetric and neonatal care. So I just kept building on and building onto my skill. And whenever I was taken to any hospital, any facility, I said to myself, I am going to be the solution. Because all this knowledge and skill has to translate to me being able to solve problems. And the only way I can be of value is if I'm a problem solver. So I just made up my mind and I said, this is gonna be you. Anywhere you appear, you are the solution. So I said, I'll not complain, because it's so easy to complain when things are going wrong all around you and you feel like you don't have control over your own life, over your own career that you sacrificed so much to build. So I said, don't complain, become the solution. So after that is when I started looking at what are the things that I need to do within this system. So while I was in management, I went on to do MBA in healthcare management because I wanted to build my managerial skills. Because I thought to myself, if I'm given a managerial job, the county and the system has refused to take responsibility of building me up and training, then I have to take that responsibility for myself. Because at the end of the day, it's my reputation and my career on the line, because it will be like, yeah, for this number of years, this particular doctor was here and this is what she did or did not do. I'll not be able to blame someone and say, no, they didn't train me to do it. So I decided to build capacity in that area, and that I found was one of the best decisions I've ever made in my life, because it has enabled me to do a lot of the things that I wanted to do to ensure that I can make decisions and also get on the table. Then the other thing that I did while I was doing MBA healthcare management and we were doing health system strengthening, I realized we don't have healthcare systems. We have disease care systems. That's when I made my decision to become a family physician. I didn't know that at the moment, but that is where now the trajectory was taking me, because I was like, instead of waiting for people to come and get sick and wait for them in hospitals, we have to do something about it. Like all these 6 years of knowledge and skill cannot just be about fixing broken people, fixing the sick. So that's when I went back to family medicine. So coming to where I am right now, with the lessons that I've learned throughout, I think some of the things that have helped me overcome those challenges was, number one, my mindset of who I was and what I had in terms of skill and of value. Because I realized that knowledge in my head is not just for me to work with my hands. Someone can pay me for my brain. Someone can pay me for my ideas. Someone can pay me just to hear about the solutions that I have. So I went into consultancy amongst other things. So you sit in a meeting for a few hours, you give your ideas, they pay you for your time. You take on a project, you give them a few solutions for adopting and implementing, they pay you for that, aside from your clinical work. So I think that is the other thing. Know your full value. That was very important for me. What are the things that I can do? I can teach, I can do project implementation, I can provide ideas and solutions. I have a wealth of and breadth of experience about the Kenyan landscape. I bring that to the table. So me coming full circle about what I bring to the table made me realize it's not just about me being a doctor, it's about a doctor being me. What do I bring to the table as me, not just as being a doctor, a young family physician? What does Mercy specifically bring to the table? And being able to really craft that well. And also the third thing that I learned is your positioning and your placement is key. If you're in the wrong place, you will most likely be misused, because sometimes the system just tells you, we don't value you. How do they tell you that? How much they pay you? How much they value your time or not, calling you and not paying you for overtime, such things. They're telling you, we don't know your value. And if someone doesn't know your value, there's always room for abuse. So making sure you're in the right places with the right people is very important. Sometimes these positions start as volunteership, like they started for me. Going to places where people see my value, they say, oh, you can lead, you can do 1, 2, 3 things, come do it here. And I kept doing that until I got to a place where I was able to demonstrate my value. It's almost like you being on stage and showing people, hey, look, this is what I can do. So having value and skill and demonstrating it are two different things. And that's one of the things I learned about overcoming these challenges of how much I make, how much I'm valued, how much I love my job, my career trajectory and progression, be able to demonstrate that value. And last but not least, the thing that helped me overcome a lot of these challenges, never give up. The only person, I kept telling myself, the only person who can stop you is you. So no matter how many obstacles I got in my way, I just told myself, listen, the only person who can stop you is you. If one way doesn't work, if one person says no to you, like I applied for so many things. I applied for scholarships. I applied for positions. They just flatly told me no. Some of them didn't even let me come for the interview. They're like, oh, we made a mistake calling you for this interview. Sorry. So just don't stop. Don't let anyone tell you no. The only person who can tell you no is you. And with that, I give it back to Andrea. Thank you.
Thank you very much, Mercy. It is always to me fantastic hearing you. And after your speech, I would like to tell you that I would like to hire you also as my motivational trainer. Even after the Barcelona conference, I had the same feeling. So this is an explicit proposal from my side. I'm joking, but anyway, I think that you really inspire a lot with your thoughts and especially with your attitude. And I think it's always super interesting to listen also to the experience of Kenya and more in general in Africa. It's somehow also an experience that I have been living in the last few years, so it's very close to my heart. And it was very valuable and interesting listening to you. My motivation now is really up. I hope also the one of our listeners. So I will give now the floor to Yelena. For those who arrived more recently, let me remember that Yelena is a family doctor from Kazakhstan. We met throughout the Young Leaders Network of the WHO. And Yelena is also very proactive in Kazakhstan, so she will share with us now her experience of becoming a GP in a country that hosted the Astana and Almaty Declaration, so a country that is very important to primary healthcare. Thank you, Yelena, and you have the floor.
Thank you very much, Andre, and thank you everyone for having me here. I'm very excited, and I will try to share my slides because I did prepare, like, I hope it's not too long, my presentation, just to give you a better understanding of what like country I'm coming from, because I believe that maybe not everyone is too familiar with that. And I'm really sorry, but like lately my laptop started lagging, so it works really slow, but hopefully you can see my screen. So I will try to show my slides from here. So as I mentioned, and as Andrea said, I'm a family doctor from Almaty, Kazakhstan. I also work as like a teacher at a family medicine residency. I'm sorry. Oh, here, hopefully it will work. So today I wanted to give you a brief introduction about my country. So Kazakhstan is located in Central Asia, and we are the largest landlocked country. So we don't really have any sea or ocean next to us, and we are 9th largest country in the world. So like it's a pretty big country, as you can see, but we only have a population of 20 million, and it's a very recent update. Just a couple of weeks ago, our president announced that now there are 20 million of Kazakhstani citizens. And our most probably popular, or maybe the best known neighbors are Russia on the north and China on the west. So, oh, sorry, on the east. And we have 2 major cities, which is Astana. It's a new capital, relatively new capital. And currently the population is over 1.5 million. This data is for 2018. So the population has grew since then. And in Almaty, we now have over 2.5 million residents. And as you can see, like most of our people, they live in urban area. And Kazakhstan is a very, I would say, as you can see here, the density of the population on average is pretty low. We only have 6.5 people per square kilometer, but as you can see, it's very diverse depending on the region. So southern Kazakhstan is the most populated region, and the density there is like 24.2 people per square kilometers. So yeah, we have like huge distances, like sometimes like hundreds of kilometers, which are like completely unpopulated. And then we can have like some cities, villages, and so on. So these are the two major cities. And as you can see, Kazakhstan is not a poor country. Why I'm saying this, you will see that later. And basically, Kazakhstan, for a number of years, it's now an upper middle income country. Sorry, that's my laptop not working properly. And yeah, as we mentioned before, Almata or Almaty, currently the name is Almaty, it's a home for the WHO Declaration on Primary Healthcare. It was adopted in 1978, I'm sorry, in my home city, Almata. And unfortunately, despite the fact that we are the home country for this declaration, Kazakhstan had a very inconsequent history of the primary healthcare development. And historically, our focus was mostly on the hospital care and tertiary or specialized care. And the funds, the financing was mostly allocated to hospital care. And just a few years ago, it was like that 90% of the budget would be allocated to the hospital and tertiary, like specialized care, and only 10% would go to the primary health care. Apart from that, as you can see from this picture, our healthcare expenditures are below the recommended by WHO. As probably you have heard that the recommended minimum is 4.5% of the GDP that should be allocated to the healthcare. But in Kazakhstan, until very recent years, you can see it didn't even hit 3%. And only starting from 2020, the healthcare expenditures started increasing, and the forecast is now that probably by 2028 we will hit 5% of GDP, but it's also unclear. But as you can guess, this increase in the budget, it's not a natural course of the events, and it increased only because the COVID pandemic hit, and we had to allocate more funds, and also they were mostly spent, of course, on the hospital and specialized care, not to the primary healthcare. And here, yes, this slide is about the health spending composition. As you can see now, they state officially that 49% of funds, they go to the primary healthcare, and only 48 plus 3 goes to hospital and daycare. But well, that's the official data, and we, I guess, have to believe that. But in reality, it doesn't really feel we don't really feel any difference compared to recent years. And here is the short, a very brief list of challenges that young GPs face in Kazakhstan. First, of course, and I think that's one of the biggest challenges here, that we still have no evidence-based approach implemented into our healthcare system on the national level. So it leads to the situation where we have a lot of medications, a lot of procedures, diagnostic and treatment ones that are not scientifically based, and they're not effective, and most likely they're not safe. So they are potentially harmful and unnecessary. And another thing is it leads to the poor quality of medical education, because unfortunately, historically, it still stays like that we have this very vertical kind of system here, where the knowledge passes down from the older generation of physicians, professors, experts, to the younger generations of doctors. And unfortunately, a lot of these senior colleagues, they do not update their knowledge. And of course, there is also a huge gap, such as a language barrier, and there is not enough reliable resources published in Russian, where these professionals could update their knowledge, to stay really up to date. And as I mentioned, the lack of evidence-based approach, it also matters. It contributes to this overall poor quality of medical education, and then poor quality of health services. Another very challenging thing is low salaries, and a bit later I will show you graphically what I mean by that. And as I mentioned, we announced ourselves as an upper middle income country, but in reality it's really not like that. And people in our country, we don't really feel like we live in upper middle income country. The next thing is the lack of trust and respect from the population and the specialists. And by that, I mean that I mentioned before that it's just very recently, I think it's from 2015 approximately, when we recommitted to the primary healthcare, and we decided that we will develop that, because starting 1989, when we first decided to fully commit to primary healthcare declaration and to develop primary healthcare, it's a very long history, almost 30 years, but still it was one step forward and two steps back, because it would depend on who would be in charge of the Ministry of Healthcare. If the person would be pro primary healthcare, some developments would happen, but then when someone else comes to replace them and they are in favor of hospital care, they would immediately shut down everything and they would change the whole course, so that there would be no consistency in whichever programs were implemented before. And it led to the situation when the family medicine residency program was completely shut down for 7 years. We didn't have that specialty at all in our medical schools. So yeah, and this is what happens. And the family physician is kind of newly introduced specialty since 2015. And that's why it took a lot of time for people to even understand. And even now, not everyone understands what kind of specialty it is. And for example, especially in public facilities, patients would see family physicians as someone who refers them to the specialist, who gives them prescriptions, who gives them sick leaves, and they actually probably give them the referrals to different diagnostic procedures, and they don't really see them as their doctors. They mostly see these family doctors as referral specialists, and basically they see them as obstacles to the to true specialists, narrow specialists. And again, our own colleagues, so-called narrow specialists, they also don't see family physicians as real doctors. They think that these are doctors who are who did not qualify to become specialists. So this is the overall situation here. We also have this program when government starts, they try to encourage actually young doctors to be family doctors, and they provide so-called state grants or state scholarships and encourage people to apply. And this scholarship would cover the tuition fee for the whole duration of studies, and also allow some monthly allowance. It's not too high, but it's kind of some kind of financial support during the whole course of the studies. And then after graduation, this young specialist would have to mandatory be referred, to rural areas to work as family physicians there for 3 years, for at least 3 years. They also would be provided with some kind of relocation funds, or the settlement capital, in order to help them maybe buy their own apartment there. And for the first 3 years, they will be also provided by the governmental apartment accommodation, and they only have to pay for the utilities. They don't have to pay for the rent. And in that way, the government tries to encourage young doctors to stay in rural areas and work as GPs. But it also is not too effective. Why? Because it recently was reported that only 52% of these young graduates, they actually go and work in rural areas. And basically almost half of them, they try to evade this mandatory obligation by getting married and getting pregnant, or applying for the next level of studies, such as master programs or like doctoral programs, or they go to army, or some of them they pay back to the government the whole like tuition fee. So people are not really motivated to go and work in rural areas, because like the working conditions are pretty poor in primary healthcare, not only in rural areas, but in the cities as well. And a bit later, I will show you what I mean. And also, as Mercy mentioned, they don't see really bright career opportunities being family physicians. And that's why after these 3 mandatory years, a lot of family physicians, they go and specialize, like they become this so-called narrow specialist, and they leave this field, they leave family medicine. And of course, a huge challenge is the corruption on all levels. It's just like, yeah, it's everywhere. And we talk when we talk about the salaries, are like the Ministry of Healthcare every year they state widely in mass media and official websites that they increase the salaries of the physicians and nurses. And here you can see this. This is an old statement from 2022, from 2020, and they promised that in 2021 the salary will be increased to 645 euro for the physicians. And in 2020, when the statement was made, they said that the salary of the physicians was 500 euro. But this is a recent poll. I just posted it today in my Instagram, and I asked my colleagues, like, is this statement true? Like, who got this salary? Because in 2023, they said that the salary would be 1,100 euro. So almost twice as it was like 2 years ago. And I asked them if that's true. And here you can see that most of the physicians, they voted. It was like after 20 minutes, I made the screenshot. So people said that mostly they would get the salary below 600 euro. And only some of them, they would say it's 650 euro. But these specialists, these 7 votes, they all work in hospitals. So you can see that hospital doctors, they get higher salaries than primary care providers. And among primary care providers, some of them, they sent me the private message, and they said that their salary is like 300 euro. So, and this picture, it shows the inflation rate. It's just like skyrocketing this year, and it reached like 25%. So basically, this like increase in salary, we can't really sense it in any way. And this is just the example of working conditions in primary healthcare. Here on the left, you can see the rural polyclinics, and here is the city polyclinics. So in rural polyclinics, it's really overcrowded, and there is like basically, you can see it doesn't really matter if it's a rural or city polyclinic. We have these doors open, and people are sitting in the corridors right next to the doctor's rooms. And the city polyclinic is not overcrowded, not because it has better organization of work, but because like in the city, people usually are more financially stable, and they can afford to go to the private clinic. Because like in city polyclinics, in public facilities, or in rural polyclinics, they sometimes have to wait for 2 weeks to get a doctor's appointment. So in cities, it's really like more preferable to go to private clinic.
And
interrupt,
you have more or less a couple of minutes left.
Yep, sorry, yeah. And yeah, this is just the example of the, because usually our doctors share the room with 2 nurses. So, and these are the patients who are like just openly, like, you know, you can hear and see everything that happens in the doctor's room. So basically there is no privacy at all, like in our public facilities. I'm sorry, yeah, my computer lags. And this is just the primary healthcare facility in the rural area, and it's only 150 kilometers away from Almaty. And it's a recent, like, it's not like from 1980s, it's just like a couple of years ago. And you can see the conditions, like there was no renovation, there is no even like running water. And this is the tool where they put water, and this is how you wash your hands. And I thought that this was the sink where I could wash my hands, and I started like I tried to open the tap, but it wasn't working. And then I realize that it's all fake. It's just for this commission to come and like for this regular kind of checkups, because like you have to have this tap water according to regulations, but in reality it's all just fake, you know. And this is the toilet outside, the only one. There is no toilet inside of this primary healthcare facility, and it's the same, it's the common toilet for the healthcare workers and the patients. And of course, like our young physicians, they are not very motivated to go and work in rural areas. But basically, as I said, even like in city polyclinics, public healthcare facilities, the conditions are not much better. So when we hold these posh conferences, you know, like the World or WHO conferences on primary care, to me, it really feels like a huge hypocrisy, because like we always brag about all those achievements, which we like got in like 5 years, 10 years, to like related to primary healthcare. But in reality, this is like the toilet outside. This is the like the problem that could have been easily solved if anyone cared, you know, but they just don't care. So yeah, thank you very much.
Thank you very much, Yelena. This is super interesting. I remember the first time you talked with me about the situation in Kazakhstan, and I also remember all these bombastic declarations from politicians and ministers and so on. And I was very surprised and very sad with what you were telling me. And I thought it was really interesting for other people to know, beyond declaration, what is the situation of primary healthcare in Kazakhstan. And on the other side, I really wanted to have Harry with us, because even as an Italian GP, when we think about England, we feel like they have pretty everything on board, because they have a nice residency in family medicine, a lot of masters, a lot of PhDs, and a lot of career opportunities. But very likely I feel that Harry would tell us that reality is a bit different. So Harry, welcome. Thank you very much for being here with us today.
Thank you.
Thank you.
Let me just share my slides. Oh, that's my emails. Are you seeing my slide normally, or are you seeing it split across two?
We're seeing a split across two. We're seeing, yeah.
Yeah. Presenter view.
How do I swap that over? It doesn't matter. You can still see. So my name's Harry. I am a doctor in the UK. I'm a GP registrar. So that means that I'm in my final year of my GP training. Yeah, I'm going to share my my perspective. I didn't want to call it the English perspective, because I think it is just an English perspective, and I recognise that doctors across England and the UK more widely have differing experiences of their training and of their work. But I love my job, I love my training, and I'm very glad that I've done it. I wouldn't change it. I wouldn't change my career path, but I am also mindful of the general deterioration in our healthcare system. So first of all, for a bit of context, I thought I would just share how much the UK spends on healthcare. So you can see here that the UK is, amongst other similar countries, other similar European countries, is on the kind of bottom end of the kind of high income Northern European countries. But when compared to countries like Kenya and Kazakhstan and even Italy, we are not doing too badly in terms of funding per person. And just a little bit of background, because I realised that family medicine and general practice is structured very differently across the world. So in the UK, there's a really strong history of general practice, and it is really well integrated into the healthcare system. It's a foundation of the healthcare system, and has been a core part of the healthcare system since the foundation of the National Health Service in 1948, and it is designed to function really well. So it's designed as your first point of contact for all your healthcare needs, pretty much, except for emergencies, where you need to go to the A&E, the accident and emergency, or the emergency room. There is continuity, so every single person in the UK should have a named GP who is responsible for them and will see them throughout their life course. And it's also comprehensive, so 90% of all healthcare needs are dealt with in primary care in the UK. And as a GP in the UK, you have a coordination role, so managing the different conditions, and if you get specialist opinions on particular diseases, as the GP, you're the one with the coordination role with primary responsibility. It's also based in the communities where people live. You have to live within a geographic region to be registered with the GP there, and it also takes a biopsychosocial approach to healthcare. It's free, so our healthcare system is a tax-based system, so it comes out of our taxes. You never see that money really, and it is free at the point of access for everybody. In terms of our training, first of all, you do medical school, then everybody who finishes medical school who wants to be a doctor does their foundation training for 2 years, and then after that you go on to your specialty training, and for GP in the UK that's 3 years, and often between foundation training and GP training lots of junior doctors will take a career gap. But despite all of the good design, the landscape is changing massively. So as of October, so recently, we've got about 27,000 full-time equivalent GPs in England. And this corresponds to 7.8 GPs per 10,000 people, which is below the average for high-income countries. And each GP is responsible for about 2,300 people. And what's interesting is that this has risen quite significantly since 2015. And there have been increasing pressures on primary care, and the government has pledged more and more GPs. In 2020, the Conservative government pledged that there would be another 6,000 GPs by 2024. So a couple of weeks, and instead GP numbers have continued to go down. Last year we continued to lose more GPs, so they're pledging without delivering. And pressures on the NHS, the National Health Service, have been getting harder and harder, and you can see here from waiting lists. So this will be when somebody comes to primary care and they need to be referred onto secondary care, perhaps for cancer investigations, or for an elective hip replacement, or whatever it could be, any referral onto secondary care. The waiting lists are now extremely long, and some referrals for hip replacement, for example, you'd be waiting for years. For a routine gastro referral, you'd be waiting for probably about a year or two. So it's getting quite out of hand, and there has been a degradation of doctors' pay in the UK, and this graph just shows it quite nicely, showing how much junior doctors' salaries have decreased since 2010, and you can see that UK doctors' pay has gone down far more than other sectors, and that is mostly because there haven't been pay increases. The pay has been stagnant, but inflation means that the pay is worth less. And then just putting that into real terms, this graph shows what has actually happened with pay. for doctors in terms of real terms rather than as percentages. And this is a deeply political issue, and I don't want to get too political, but this is just an interesting graph that shows how the political party in power in the UK has affected the pressures on junior doctors. And the result of this, so increasing burden, decreasing opportunities to help patients, and reducing workforce, is resulting in the UK having an exodus of doctors. So the UK is just hemorrhaging its doctors, and most of my friends, or a very, very large proportion of my friends, have moved to Australia or Canada or New Zealand, and some of them have come back, but quite a large proportion of them have not. And that is reflected in this graph that shows that for people who have practiced in the UK, more people are leaving the UK than coming to the UK. And this graph just shows how much, this is not specific for doctors, this is all NHS staff. It shows that people are just leaving because they are fed up of the burden on their work-life balance and their stress mostly, with also consideration about pay. So in order to try and plug the gap, the government has been recruiting much more from abroad, and medicine is an international qualification, and doctors should be able to move around the world and practice globally. But there are huge problems when the UK is taking its doctors from developing countries, and 2/3 of the newly registered doctors in the UK came from abroad last year. So the result of this is that the UK health system is in an absolute mess. Junior doctors are completely disengaged and completely kind of burnt out and worn out. And so second time in history, the junior doctors have been striking, the consultants have been striking as well, and this is the latest declaration of when the strikes are going to be, and it's going to be the longest strikes ever in the NHS's history. And the result of this, it's because the government won't sit down with the junior doctors to discuss things like pay and working conditions, but instead are now blaming the striking junior doctors on the worsening waiting lists. And so I just thought I'd bring back this graph that shows that actually the waiting list got far worse before the junior doctor strikes happened. And that kind of brings me on to the topic of moral distress and moral injury. And it's something that often gets talked about in the UK. And lots of people don't know what moral injury or moral distress is. But moral distress is when you feel like you're not able to deliver the level of care that you want to be able to deliver. And so you receive a moral distress from that. And then moral injury is when you have repeated episodes of moral distress that actually affects on your functioning. So that could be mental health problems, depression, anxiety, or insomnia, or kind of burnout at work. And 78.4% of doctors, junior doctors in the UK, experienced moral distress, not being able to deliver the care that they want to be able to deliver. And over half of them, that was affecting their functioning and resulted in moral injury. And when the British Medical Association did some kind of research looking into why is it that doctors are having this kind of moral distress in the UK, these were the reasons that were given. So it was mostly around there not being enough staff to provide the care that was needed, and a lot to do with kind of mental health and emotional fatigue. But that's all very negative, and I didn't want to just kind of leave in a negative space. And so I just wanted to talk quickly about resilience. So Health Education England defined resilience as the ability to bounce back, the capacity to absorb negative conditions, integrate them in meaningful ways and move forward. And the first thing I wanted to say about resilience was resilience has become quite a controversial topic in the UK because it's been used as a way of shifting responsibility from the system and from adequate government funding and structures onto individual responsibilities. And so I just wanted to re-echo the words of David Oliver, who wrote in the British Medical Journal about when resilience becomes a dirty word. And he says, but absorbing any unacceptably and avoidably negative conditions makes resilience a dirty word. It shifts the blame and responsibility for doctor struggles away from what are often over-politicised, understaffed, underfunded, badly organised systems and onto individuals. And then he goes on to say, it's an understandable impulse to give reassuring platitudes and shift responsibility for well-being onto individual practitioners. But a resilient system is what we need, one that adequately recruits, retains, values and supports its employees. So system resilience is by far essential, is completely essential, and you can't talk about individual resilience without also addressing system resilience. But on the issue of individual resilience, I just want to talk about some of my experiences and things that I've found helpful, because I do enjoy my work and I'm not currently considering moving to Australia or Canada.
1 minute, thank you.
Cool. I think this is my second to last slide. So I found things like peer support groups really, really helpful. So we have a really good training scheme in the UK. I have colleagues who are doing the same thing, going through the same experiences, and peer support groups have been shown to reduce the rates of burnout by 50%. I have a really good mentor. There's a really good mentorship program with that. I have a great supervisor. Gratitude makes such a difference. And then I think it links slightly to I think what Mercy was saying before about kind of knowing your worth, so mattering and feeling like you can contribute meaningfully and that you're valued in your workplace. And then a lot of people are reducing their hours. They're going down to 80% time because they can't cope with the stress of full-time. And then for me personally, I've recently returned from a year out of my training program. I did a diploma in tropical medicine, and then I moved to Uganda with my wife for 6 months. And I found that has been really, really a massive boost to my resilience. Yeah, I've found coming back to the UK system, it's been really refreshing having the Ugandan experience as well. And then also there is reason to hope that there might be political change in the UK, because all of the opinion polls show that in the next general election, which is going to happen at least by January 2025, is very, very likely there'll be a change of government. And so there is some hope for the future. And that's all I wanted to share. Thank you.
Thank you very much, Harry. I'm very glad to hear that there are strikes going on between young doctors, I would say, all over Europe. In the UK, you are doing it very well, because I've been reading a little bit about them, and I know you're doing consecutive strikes, and this is very important. In Italy, we also tried to start some strikes, but not in I would say a very effective way, just 1 day or 2. So I really hope that your struggles will be fruitful. I would say that, Mercy, we need a little bit of your motivational support now, because after these 2 presentations, I feel no, I'm joking. So we have now a few minutes, I would say 10 minutes, and for questions and answers. So I will now leave the floor. Thank you very much, Patrick, for raising your hand. I will immediately give you the floor. So please feel free to open your mic.
Hello, colleagues. My name is Patrick, and I'm close to retirement. So what I'm hearing today is something which is very touching. I work in the special program for primary health care at WHO. I was attending the Astana conference, and I saw you guys on stage and enthusiastic for primary health care. So hearing you today is a bit chilling, and I want you to know that that is really concerning. Not concerning because I don't know who's going to take care of me now in my older years, but concerned that together we have a common understanding of what healthcare system can accomplish. From my journey, which is about 40 years in the medical world, starting in Switzerland and then in about 80 countries in the world, clearly I can see the tensions between the increasing number of solutions, the aging of the populations, and the fact that there are some fancier jobs than healthcare. And so it does not mean that healthcare is not a very, very beautiful professional activity, but it means that we need to feel comfortable in drawing the limits, and this is something which is always very difficult because now that there are many more possibilities, pharmaceutical industry does not hesitate to charge $1 million for one dose of genetic treatment for a very rare condition. And if we have to allocate scarce resources, where do we start? And part of the scarce resources is the health workforce, and that's what you're talking about. So you need to be able to be recognized, to grow, to deliver the best that you can, but with a sense that you're also being protected. And that I have no solution, but my question is really, do you feel that this concept of primary healthcare that WHO is now proposing is the right place to basically find a common sense to what we should do? Because it's also frugal, but I'd like to hear your reflection on this and see if this for you is a real path for the future. And I will stop there, but you can be sure that I will tell my WHO colleagues to watch the recording of the session.
Thank you very much, Patrick. So I would like to have a quick reply from any of you. And I would like also to reply to Patrick's question, but I would leave the floor first. I don't know if any of you would like to reply, especially to the last question, which I think is very important to our discussion.
I can start us off, Andrea. And I think I love that question because for me, I strongly believe, and this comes from a deep place of thought and conviction, that primary healthcare is our only recourse. Because one of the things that has convinced me of that is because I had the privilege of studying and training in a country that has a functional primary healthcare systems. And I think one of the things that I thought while working there was, this must be a dream. This can't be true, because I had never seen a system work so well, not perfectly, but well enough to deliver healthcare for everybody. And I actually saw it in action. I saw it being done at a very low cost with minimal resources. And that deepened my conviction that we have no other recourse. We are preparing for the next pandemic, not if, we know it's coming. We're preparing for it. And we know from evidence that it has been shown that countries that had well-working primary healthcare systems did very well during the pandemic, had lower mortality rates from other non-COVID related complications and conditions as well. So for me, I deeply believe that primary healthcare is our only recourse. It was one of the beliefs that made me go and study family medicine. It is why I aggressively advocate for family medicine and primary healthcare, because if that works, everything else works. And I love the WHO approach and
the emphasis on a whole of society approach, because every time we talk about primary healthcare, we kind of sort of forget that little piece that says whole of society, meaning all sectors, all people, all sections. So it is not a half-baked definition. It's the perfect definition to move us forward towards population health, because the longer people are living, the same child that you were taking care of when they were 5 years old, one day will become 90 years old. So if you don't have a life course approach, a whole of society approach, all that, you're missing so much. So I think to your answer, Patrick, for me, my answer will always be primary healthcare is our only recourse. And that's why building the next generation of primary healthcare providers, making them know it works, giving them passion for their work, giving them space, mentorship, sponsorship to help them grow is critical. Thank you.
Thank you, Mercy. Thank you very much, Yelena. And then I raise my hand as well.
Yeah, I just wanted to second Mercy on that. I also personally am a fan of family medicine and primary healthcare system. And I also believe that all healthcare systems, they should focus their primary attention on the primary healthcare, because like I come from the country where healthcare system oriented on the secondary and like tertiary care mostly. And I can see, especially as I mentioned before, the lack of evidence-based approach, it can be really, really harmful. And as we mentioned, here is a safe place, so I will tell it here. Even during COVID pandemic, when I was included into our like expert groups on COVID-19 response, and we also like kind of supervise the patient histories, like patient records, medical records, so those who were hospitalized and those who died from COVID. And I could see that this lack of evidence-based approach, because we started like very aggressively hospitalize everyone, even asymptomatic people. And we started treating them with this anti-HIV medication, even those who were just positive, like tested positive for COVID-19, and then they had a lot of like side effects and like after this treatment, and this was completely unnecessary. And some people who really did not require hospitalization and that they could like safely be monitored at home, they went to the hospital where viral load was like very high, and they would have the severe like progression of COVID-19. And I could also see that because like no one in the world would know what to do, but in our countries hospital care is very aggressive. Like they would start doing a lot of like unnecessary intravenous like antibiotics and like other absolutely not evidence-based medications which don't even exist in other countries. They nowhere in the world they use it, but in our countries they just give a lot of like fluids and everything. And I could see these patients who died due to the overload, hypertensive patients who were deprived of antihypertensive medications, they would die from stroke. And probably if they stayed home because they didn't really require hospitalization, they might have survived. We don't know, but I could see that how this invasive, unnecessary, and aggressive treatment in some cases would lead to this like poor patients' outcomes. So I strongly believe that the emphasis on like primary healthcare and evidence-based medicine, this is the only true approach. And it's not just about the COVID. This is like largely what happens in countries like ours, basically the whole post-Soviet region. We have such like, you know, the crazy thing is like planned hospitalizations for people with non-communicable diseases. Like twice a year they get hospitalized because they just have this like hypertension. And what do they get there in hospital? They get IV treatments, like IV infusions, also unnecessary and not evidence-based medications. And for that period of time they don't get their like antihypertensive pills. And sometimes like 2 or 3 weeks after this hospitalization, after they get discharged, they also can develop like stroke or any other complication. And no one actually, it's not even traced here. So I strongly believe, I am a fan of family medicine and primary healthcare. Thank you.
Thank you very much, Yelena. Let me permit me just to give a quick reply also to Patrick's question, which, as I said, I think is very important. So, Patrick, I think that in this room we have a lot of people advocating and championing for primary health care in their own respective countries. So I feel like we are all very committed in here toward primary healthcare. I remember that I decided to become a family doctor when I first read the Alma-Ata Declaration of Primary Healthcare. And since then, I started deepening the study of PHC, and I thought, okay, this is what I want to do in my life. And I think that we all believe in that, and we all believe in a whole society approach, and we all believe in One Health. But let me also share a more critical view on the last, I would say, declination of primary health care as a matter to achieve universal health coverage. So I think there is a huge problem today, especially in Europe, but I would say all over the world, when we substitute the word right to health, with the word universal health coverage. And this is what is happening, for example, in countries like, I would say, the UK, but even in Italy, where we are assisting to a progressive and inexorable shift toward private healthcare. And especially in countries like the UK, Italy, but also other countries outside Europe that had a tax-based system in their healthcare. What we are seeing today, and what we as young professionals are very concerned about, is this silent and progressive privatization of health, which I think, and I'm firmly convinced, the WHO is somehow supporting with this declaration. Even in the last draft declaration that was delivered in the last Health Assembly for the 5 years after the Astana Declaration, which happened just a few weeks ago, we had no mention about education in primary health care. If you look back to the draft document that was delivered, you will see that there is practically no mention of primary health care, and what all the three interventions have clearly outlined is that in most countries, family medicine is not even a specialization. So of course we have professionals that feel undervalued if we don't give them the possibility to specialize in this own field. There is a big contradiction, because on one hand we are saying that it's the pillar of the health system, but on the other hand, we are not providing equitable conditions compared to other specializations. So this is something that WHO really please need to focus on, understand, and tackle. Thank you. Sorry for my passion in replying. I would like to ask to the participants if you have any other question. Okay, let me just wait a second, Patrick, to give you back the floor. But I think that there are no questions, and actually we were planning to finish a little bit earlier. But it's nice because I mean, I'm not going to shut down the webinar, because I mean, if we are willing to stay here and debate, it's super nice. Patrick, you have the floor. Thank you very much.
No, just to say that I heard you loud and clear, and your aspirations are very close to my heart. To put it in simple words, we would all like that health be as much as possible a public good and not a commercial commodity. And of course, there is a reality in a world where private sector brings a lot of initiative and enterprise, and so we also have to cope with that. So part of our role, I think, is to continue to advocate for the most health possible for every people at no financial expenses, because once somebody suffers in their health, everybody should care about them a little bit. The question is more up to what point can we can we deliver? And in Europe, we have a number of countries which have had very broad social health systems, UK, France, the Scandinavian countries. And of course, they face the limitations of cost. And then you have mixed systems in other places like Italy, Germany, or Switzerland. But the most important is that health does not remain limited just to the health professional, and that basically every people we serve know that they also contribute to it. So I leave it there, but I hope that you realize that I heard you, and I will share what you said with my colleagues, and I look forward to the next encounter.
Okay, thank you very much. I see there is a hand from Aisha. Aisha, please. You have the floor.
Hello, everyone.
Hello.
Thank you for your insightful comments. I also believe that primary healthcare has a big role to play in our society. I, for one, can say that I've seen it. I am a family physician who actually goes to the community, treat different diseases like non-communicable diseases, and I can see a difference that it makes to the people in the rural areas, like the difference in their smiles on their faces, the fact that they get medication on time, they actually get healthier and healthier as the days go by, and the adherence to medication has also improved. So I do want to say, for one, that everyone has a role to play, and primary healthcare does work in our society. Thank you.
Thank you very much. And we really need very good family doctors, especially in Africa, where they're so rare. So thank you for doing this. If there are no other questions, I really want to thank you very much for your participation. It has been, to me, super interesting, and I was super happy to have these experiences coming from 3 different continents. And I hope to see you again in our upcoming webinars organized by the European Forum for Primary Care and also the Young EFPC. And for any question, please feel free to visit our website. You will find all our contacts, and let's keep in touch. Have a good afternoon, and thank you very much to all of you. Ciao.
Thank you.
Thank you, everyone. Bye-bye.
Thank you.
Bye-bye.